That's the second part of this opening session now with the lightning talks. I think we have here already some of the speakers in the room. Louisa, Nolan. A round of applause to Louisa from Public Health Wales. Thank you for joining, Louisa. We'll put the seat arrangement here. See if you don't. You need to do slides. You can use then the lectern. And have you shared your PowerPoints with Reese? Okay. So David, Wyndham Lewis is going to be also a lightning talk speaker last minute because Elena Patelis is not able to join. And we have Iñaki Gutiérrez also. That's going to be the last in this session to speak. Last to speak has a bigger responsibility. But Iñaki is bringing the perspective from also another nation, Euskadi, in Spain. And we'll bring a perspective on policy making and technology assessment from the end. So I think, oh, and obviously Mike Cooper, yes, thank you so much, Mike, for joining us in the replacement of Adam, but in fact we have better served with Mike. He's the program manager of delivery in Life Science of Wales. Thank you so much, Mike, for joining last meeting from your busy schedule. I know that Mike was also here yesterday. I had good feedback from Mike and on day one, but I'm sure also this panel is going to be interesting and relevant for what we want to accomplish here, driving change through data insights. That's our goal here. David, if you can also take the floor here for the presentations. And Louisa, you want to present from the lectern or from there? Maybe from the lectern is better. Yes. Okay. So now we have all the stage complete. I hope you enjoy this session.
I'm just building the tension here. Mostly for me and the technical people, I think. There we are. So hi. Yes, I'm Louisa, Head of Data Science at Public Health Wales, and I'm going to talk to you about data science and analysis in public health. It's interesting, yesterday we were talking about what the definition of secondary use of data is. And we talked about the bit, you have the primary use about directly affecting patients. And then we often think of secondary use being about research, like some of the amazing stuff that Evan's just been talking about. But this more sits in the middle. So this is really about getting the right data to the right people at the right time for people within the health system to help make decisions. So it comes in two parts. What can we do with data? And then at the end, some questions about, really, why aren't we doing more? So part one, I've got a story to tell you. It's quite a simple story, but it illustrates some of these points. So these are, what can we do with the data? Why is it? I thought I had a different slide, actually. I hope I've given you the right slides. Oh, well, probably. Anyway, we'll do our best. So the three things in the remit were, how do we use data to help to understand what's happening? How do we use data to inform decision making? How do we use it to help delivery? And then what opportunities can we find by using the data for AI and data science? So we start here with a dashboard. Not all dashboards are good. Just chucking data into a dashboard and expecting people to understand it is bad, but this is a good dashboard. So imagine you're a board member at Public Health Wales and it's your first day and you want to know what's happening across the system in Wales, across health, public health, and also the things outside the health system which might have an impact. So we created this dashboard across our strategic priorities, and the board look at this in every board meeting and discuss it in every board meeting, which for me as an analyst is a success just on its own. And it's had an impact. So the story I'm going to tell you about today is that the board looked at this, and they looked at the excess deaths, and within the excess...
We have to have these for the online viewers.
Oh, sorry. Apologies to the online. Apologies to the online viewers. So they looked at the excess deaths, and really high excess deaths and growing excess deaths in diabetes. Now, we know that type 2 diabetes is mostly preventable, which is a public health thing. So the fact that it's growing was something that we wanted to look into more. So this is here. So here, this is, yeah, these are definitely an older set of slides. Never mind, we'll work with it. So this is about driving prioritization, looking at that, something that's growing, that's a public health issue, excess deaths in diabetes. So the next step was, what is diabetes doing? So this is a pretty grim picture. This is primary care, the counts in the primary care diabetes register over the last 10 years and a bit. And as you can see, simple line going up, not much variation. An increase of 60,000 people over that time, which is an increase of 40%. Most of this is type 2 diabetes, and most type 2 diabetes is preventable. So then, also we have diabetes we know is a risk factor for cardiovascular disease. So we look at what cardiovascular disease is doing. So this is interesting. The cardiovascular disease has actually come down, but then it flattens off a bit. So what's going on here? We know that the treatment of cardiovascular disease has improved, but the flattening off, there's obviously something that's acting against that improvement in the treatment as well. So then we look at this. Why is it happening? One of the risk factors for diabetes, one of the amendable risk factors for diabetes is obesity. If you're living with obesity, you're almost twice as likely to have diabetes as if you're not. And again, pretty grim picture for Wales. You can see the increase in obesity over the last 2 decades or so. So then we look at this, we see what's happening now, but then this was the new bit that we did. And this was really where we began to add some value. People knew within the system that diabetes was a problem. They knew that obesity was a problem. But here we look at the projections, and you can see it's a fairly convincing projection because it hasn't warmed about very much, so it's quite easy technically to do the projection. If we continue, in the next 10 years, we'll have another 22%, an increase, another 22%, the 47,000 people with diabetes. Now, the system's already stretched. We can't really do this. We know that we can prevent some of this. So, these are definitely my old slides. I'm so sorry. I don't want to talk about that. I wanted to talk about something else. So what do we want to do with that? So that slide, going back to here, this slide we took and we presented this to senior leaders. Like I say, people knew that diabetes was a problem. They knew that obesity was a problem. But it was until they saw this thing, at this point, showing this slide to the senior leaders, that really kind of crystallized it in people's minds. So we use that to make a powerful case for change. So bring this together, showing this data, telling that story to the senior leaders, CEOs and so on. We brought together the Tackling Diabetes Together programme. So this is a programme led by Public Health Wales. It's across the system, bringing together different people to focus on that problem. So we had 3 inputs to that, really. We knew that 10% of the NHS's budget spent on diabetes. We know that most type 2 diabetes is preventable, and we had the killer stat, that chart. And that really was the bit, bringing those things together, telling that simple story to get people behind some funding as well for the Tackling Diabetes Together programme. I don't want to talk about the things, the actual initiatives too much, because this is really about the data. So the next thing after that was we've identified the priorities using the dashboard. We've made the case, so we're doing something about it. So we are making decisions about delivery from this. And then the third part of this, which if I had the up-to-date slides I would show you, was really about what then are the opportunities around data science and AI. So the things that we're looking at now, this really, even the projection is quite simple stuff. Just bringing it together, showing people, telling the story. As a data scientist, we want to do more complex things. So there's a number of things that we now identify that we want to do. So the first one was looking at some demand and capacity modelling for diabetic eye screening to see whether we could get more people through. The second one was to look at what did we do then? The weight loss modelling. So doing some modelling, looking at different thresholds for weight loss drugs, looking at the costs and benefits of those. So these are slightly more advanced methodologies. Then we have some other things that we've just made a start on. So looking at policy simulation, looking at modelling impacts of different interventions, and one that I think is really exciting around the NHS app. So one of the problems with the excess deaths, we can see that we might get excess counts from increased obesity, but why there are also excess deaths if it's preventable and treatable, we know that there's only a very small proportion of people, I forget exactly what it was, I think it's maybe 40%, maybe under 40% of people who get all their 8 care processes at the moment. So one of the purposes of the Tackling Diabetes Together programme is to not just to reduce to halt the increase in prevalence, but also to improve the outcomes of people with diabetes. So one of the things we want to do is to improve self-care. So we heard yesterday about the NHS Wales app. So we're looking at whether we can get the data into there so that people can see when they're supposed to go for their tests, what their own numbers are, so that they can take better control. They know what they need to do when. We can also, I hope, help to use that data to help us do the monitoring and evaluation of those interventions that we're doing through the Tackling Diabetes Together programme, so that we have both the primary use for the data and the secondary use of the data. And then I think there's other things that we could get into that I would really like to be able to do, like personalised risk. So a GP could sit there and see who were at the highest risk and could focus on those people first, that kind of thing, building that kind of thing in. So there are some really exciting things, some really good opportunities that we have from what we've identified, starting just with that very simple dashboard, looking at excess deaths, going through that deep dive, doing the projection, mobilising the system behind, let's focus on diabetes. And then there's some more things that we can do across the system. So, yes, those things. So the question is, we've done that simple bit, and that's great. And then I've talked in the future about, oh, we can do all these other things. These would be really good. It's not like they're new ideas particularly. So the question for me is, why are we not doing more of that cool stuff? Yeah, I had a better slide than this. Should have sent the right slide, sorry. But this will do. So why aren't we doing the right stuff? So I want to start with data quality. So we start off, everything is based on data quality. We struggle sometimes with the data quality. We know that clinicians are really busy. It takes a long time to do the coding. How can we really understand what's happening in the system and the pressures on the NHS if we don't really know what's happening? So there's something about making sure that we get that value back to the people who have to do the coding. And there's another really, again, really exciting opportunity here. How can we use things like ambient voice technology to help with that coding, to take the pressure off? And I think this is somewhere where actually the technology really can help. It doesn't have to be 100% right all the time, but even if you get it to do 50% of the easy stuff, that still halves what people have to do. So there's some really exciting stuff in that. It's an important point about capability. In the NHS, we don't have professions for digital data and analytical staff. So currently there's no competency framework, there's no learning and development framework. We tend to use fairly outdated job descriptions, so when we're recruiting, what we're asking for isn't recognised by people outside and we don't bring people in. And I think that probably means we're slightly behind in what our potential is amongst our analysts, digital and data scientists. And part of that is about being able to tell that story. It's easier to tell the story when you've got the right slides, but I've got through it somehow. Maybe that's something I should learn as well, about telling that story. So I talked at the beginning about dashboards. So we have lots of dashboards, we have lots of information about diabetes, but actually the thing that made the change, the thing that was the catalyst for change, was pulling out that one thing and saying, look, this is the thing that's happening. Not leaving people to fight through loads of dashboards to try and work that out for themselves. So an analyst is not someone who just is a data manager moving data about, but is able to tell that story and use it to affect change. And this comes back to understanding the value. I think It's all built on that data quality and data collection. We know that clinicians come to us in Public Health Wales and go, we want to see cardiovascular disease by small areas, which is difficult or it's impossible. But actually then we can go back to them and say, well, you can have that, but what you need to do is to make sure that, that somehow you're doing the coding gets done so that we have the data so that we can do that. We need to close that loop so that people can see what's happening. Data access, well, we've talked a bit about that. I think there's a cultural aspect to that as well. It is difficult when we have Wales, it's not that big, but sharing data even between health boards and Public Health Wales can be difficult sometimes. Yeah, we've talked quite a bit about that before. And then I want to end with technology. So my dream would be, what we really want here is, as I said right back at the beginning, to have the right data in front of the right people at the right time. We have a huge opportunity here. You heard a bit about the National Data Resource in Wales yesterday, and also quite inspirational about the French version of that as well, which is already up and running. This is a big opportunity for us. We still have the cultural and data access, legal data access issues, but if we can automate some of those data flows, automate some of that reporting, we won't have to go to, well, I don't want to overstate it. We won't have to go to Emma and spend 4 years putting data together. Hopefully we can automate it. We can see what's happening, I don't know, maybe every month. We can look at outcomes. We can react more quickly. We're not waiting. We're not looking at 2021 data in 2025. And I think that's a huge opportunity for us. I'm very excited about what we can do with that. It also gives us the opportunity to do more big number crunching. Some of this data linking, you can't do it on a laptop. So I am quite excited about the NDR. So I think, and we're doing some work around capability as well, I think the things that are stopping us, we have some parts of work that are helping to take us forward, but there is, as ever, much has been done and there's much more to do. And hope, yeah.
Thank you. Thank you for setting the ground. Mike, you want to address from the lectern also, or you have a presentation, or you...
Good morning, everyone. So I'm from the Life Sciences Hub in Wales. I'm Head of Programme Management. Yesterday you heard from Rodri in the fireside chat about some of the work we're doing at the Hub. And today I'd like to expand on that and share how we are trying to address AI into the NHS. So firstly, here's a little bit about who we actually are. So we're an arm's length body of Welsh Government. We're an independent body, and we work as a team to try and act as a front door to industry, but also work with public sector to drive solutions and innovation on behalf of the patient. So if you can see here, we have three key drivers. I mean, firstly, to improve and enhance patient care and experience. And we look at that every day. That is what we are passionate about. Drive productivity for the clinician. So how do we do more for less? How do we improve systems? How do we drive value and remove waste? And lastly, we're also co-funded by the Department of the Economy. So we also look at how life science in Wales can be driven forward and grown, basically. And I call those our system needs. Now, if you look at this from two perspectives, firstly, we are the front door to life sciences in Wales. That means we get a large number of inquiries from innovators, CEOs, passionate people who want to drive their solutions forward and come to us. And I call that kind of push. So that is them pushing on our front door and looking for help. The other perspective is for us to identify through patient need what direction we need to take from an innovation aspect to be able to draw the right innovations into our healthcare systems. And really, there's that tension there. And what we've heard over the last couple of days with respect to AI in particular is what are the opportunities, but also what are the pitfalls we need to try and avoid, or at least get our arms around in terms of governance, in terms of infrastructure, in terms of big data, in terms of how do we move forward together on behalf of the patient with pace, but also with control. So let me start with the front door piece. So I'm not expecting you to take all of this in, but essentially how we act is every year we get about 400 different innovators knocking on our door, looking for help. And every year, I would say, and growing, we get about 100 different inquiries from AI and digital-based innovators looking for support. Our job's to try and find them the right door or to champion their needs directly. But each one of their innovations is going to be very different. And whilst they're passionate and there may be a solution that supports the whole of Wales, it may also not be that solution. And therefore we have to be objective and we have to work out, firstly, what do they want? And how do we refer them to the right place and champion on their behalf? And there will be golden nuggets in there that we want to be able to grab. We want to be able to accelerate their journey, their path into public health. So our job there is to connect and convene, to integrate, to accelerate, to advocate on their behalf. And it may be something like an app or some piece of software. It could be something bigger than that. It could be a whole solution to a pathway. But each one will be different. And if you think about all the aspects of what we've seen over the last couple of days, all of those things have to be considered. So what about the pull pathway? This is where we're really starting to redefine how we operate with respect to some of these big challenges. So here, this is a co-production, by the way. This is not our work in particular. We've worked with Scotland, we've worked with Norway, we've worked with a lot of other nations to gain exemplars as to how do you drive needs-based solutions into public sector health. So if you look at this in a bit more detail, and if you take, for example, the leading cause of death in Wales currently is cancer. If you break that down, it's a whole huge number of diseases and a huge number of pathways. But if we understand those pathways in more detail and try and prioritize in terms of need, then you can start to work out, well, okay, how do we truly understand what the problems are and how do we drive the right solutions? And we can't do it alone. It takes all of us. It takes a village to raise these children. And so many people here and many people who have been present throughout the 2 days are involved in some of this work. But essentially it starts with the patient pathway. So if you took lung cancer as an example, what is the patient pathway for lung cancer in Wales today? What's that value stream look like? Where are the gaps? Where are the obstacles? Where are the pain points? How do we understand that more effectively to drive change? And to drive change in that controlled manner. So we do technology and horizon scans. We've got a superb sector intel team, and they will put together reports that identify, well, what's out there? What's happening in Wales currently across those 7 health boards and those 3 trusts, those 2 organisations that are used for advice? How do we get to the stage of where are we today? What's the baseline? And then we've got our partnerships team who will reach out to the strategic clinical networks to get their feedback. So we will go to the networks, we'll drive workshops that say, these are what we are seeing as the pinch points. These are what we are seeing as the options in terms of solution. Give us your feedback. What are you feeling at the front line? What are your patients feeling? And how do we try and connect the dots? So with that clinical feedback, we then try to confirm priorities, and then we deep dive into the technologies. And this is where it could be precision medicine, very much AI. AI is across all of these opportunities and all of these solutions. And then you ask those key questions that we've all been asking this week in terms of systems readiness. Are our hospitals ready to receive these solutions? If not, what needs to be done at a higher level and a broader level to try and address that? There's no point trying to take a solution that may be ready, but our infrastructure isn't. Similar with data, similar with documentation, to be able to drive things forward, it's not just a single data point, a single solution, it has to fit. So our role there is to try and work out, okay, what are the system requirements? What's the appreciation around procurement standards as well? So maybe this is already in flight. So we have to collaborate, we have to communicate, we have to understand what else is going on. Due diligence, company credibility, is this adoption ready? What are the industry inputs and reviews that are out there, and what can we learn? What evidence base is there elsewhere on the globe? So are there other areas where actually this has already been done? So why are we reinventing the wheel here? How can we learn from that and drive this forward? So all of those aspects lead us to a funnel of solutions, and then we look at how do we build those project proposals. So it doesn't stop at that desktop exercise. It's then about, well, okay, what's the next step? How do we get this to where it needs to be in an environment where there's already tensions, there's already pressure on systems, there's already things that are taking up everybody's days. So we have to somehow find those projects, those programs, the resources, the funding, everything that's needed to drive that innovation forward. And of course, we're a nation. So there's 3.1 million people here, and everyone deserves that right to a solution. So you might start small, but you've also got to consider size and scale and adoption across the whole nation. So all of those aspects have to come into being. And I would say we're building this plane as we're moving through. So, you know, we've got a program of work. It covers the Tackling Cancer program, which is a coalition of the willing and mandate through Welsh Government to drive solutions to cancer in particular. But as we work through this program, you know, there's some fantastic opportunities to really drive solutions on behalf of the patient, but it can't be done in isolation. It has to be done collectively. And so these are what I believe are the key considerations that we have to look at, we have to consider to get this working well. So firstly, patient first. I think it was mentioned by Helen on day one, you know, do no harm. So this has to drive benefit. It has to be better than where we are, either in terms of pace, in terms of accuracy, in terms of diagnosis, in terms of time frame between referral to treatment, all of those aspects, or, you know, ultimately getting back to wellness at the end of the day. It takes a village, so collaborate, communicate. We work with all the health boards, we work with many organisations, and as a devolved nation, there are 60 or more different organisations involved in all aspects of healthcare. So it's, you know, back to that referral piece on the second slide, where do you take the solution to get the best outcomes? So it takes a village. Collaborate, communicate more. Identify the key stakeholders. So how do we drive this forward in the right manner with the right inputs and the right outputs? Funding. This one's huge. You can get the best projects to a really good stage of business case, opportunity, but unless you've got the money to do it, it sits on the shelf. So really it's about how do you ensure those projects can get executed on? How do you prioritize the right ones that are going to make the biggest difference and get them in to the right healthcare system such that they will work? So knock on every door and knock again. Okay. Work with experts, both from a user and a supplier standpoint. So our job as a life sciences hub is to be the glue between the need and the supply. So where that supply comes from is we need to be as in bed with those guys in industry as we are with those in the wards. So to be able to make this happen, how do you carry that baton from one end to the other? Okay, understand the data path. What's changed? Are there any risks? That's been discussed ad nauseum the last couple of days, and rightly so. Understand the pitfalls of going too big, too quickly. Build a path. We talked about pilotitis yesterday, but actually a good pilot tells us so much but it's ensuring that it doesn't stop there. That once we've built that pilot, we understand how do you then size and scale. Information governance is complex. We also heard about that yesterday. So actually use the experts, right? Ensure that we are maintaining the right pathway to get things done quickly and compliantly. Procurement, and then lastly, appreciate the change curve and be that change agent. We need passionate people, but we also need objectivity to be able to drive things forward, and impartiality to make sure we are choosing the right solution, not just the one that shouts the loudest or knocks the loudest on the door. So lots going on, certainly in the area of AI, but what I would say is it doesn't start with AI. That's part of the solution, not the problem. Understand the need, define the problem well, and explore what is the right solution to get you there. Thank you.
As we have Elena Patelos cannot join us, and fortunately David offered to share some reflections. So we are now going into closer to reality, and a case study from an interesting center of excellence. Go ahead, David.
Testing. No. So the request from Paul was to look at an area where, based on our reflections from the last couple of days and what we've been hearing from you all, where we feel that the secondary use of data is, I think, and you'll excuse the pun as you'll find in a minute, it is going to run into a sort of brick wall in terms of some transformation of the NHS, which has some very defined deadlines. New hospital programme in England. So this, a little bit of context for everyone, just in case you haven't come across it. So this was the announcement a few years ago by Boris Johnson that we were going to throw up 1,000 hospitals in about 3 weeks. Obviously that didn't happen. However, over time it has evolved into a programme that is now very much in flight. Back in January of this year, there was a final sign-off of the first wave of that programme, so the set of new hospitals for England, broken into 3 phases, 3 waves over 15 years, with 16 new hospitals in the current 5-year period. Highlight a couple of groupings within that. So you have 7 what's called the RAC hospitals, that is reinforced aerated autoclaved concrete. You may have heard it in the context of schools in the UK. So this is the concrete that's literally falling off the buildings. The hospitals in these cases are falling down around them. So 7 of those 16 have been prioritised because the current hospital site is built of that RAC material, and they will not be safe to occupy pretty soon. So they've got to do something about those top 7. The RAC sites. In that wave 1, there are also a further 9 non-RAC hospitals, so those are prioritised into that first wave for other reasons. In terms then of Atos's engagement, actually I'll just jump back a second. In terms of Atos's engagement, we started work with NHS England back in 2020, 2021. And produced a document titled as the Blueprint for Digitally Advanced Hospitals. I'm afraid you'll hear me voice my frustration several times in the next few minutes. The fact that we keep referring to it as hospitals. There's a huge amount in there which is actually about the digitisation of the health system and how the new hospital fits in the context of that, because actually, of course, what you're building here needs to be based on demand and capacity modelling that assumes a lot of movement out of the hospital setting into community, into social care. However, because it's a new hospital programme, all the titles at the top say hospital. So as I say, I'll get frustrated about that a couple of times during the presentation. So that Blueprint for Digitally Advanced Hospitals was a consideration about what technologies and data were in prevalent use in healthcare globally at that point. and also a forward look of 2 years, 3 years, 5 years, 10 years, what Atos perceived as the technology and data infrastructure would support health and social care over that time period. Now, obviously, we're 5 years into that now, and I suppose the good news is it doesn't look like we got it too far wrong. The Centre of Excellence then. So this is actually a relatively recent creation. It's an industry-led partnership that's been formed with Atos and 3 other large global digitals. I can't name them yet, unfortunately. We're actually not having our public launch until November, so this is a bit of an early tease. And supporting with that an ecosystem currently of about 40 to 50 small and medium enterprise across a range of technologies, which I'll touch on in a second. A set of NHS trailblazer organisations, so these are the organisations who are feeding us the exam questions that they want answered. Again, I'll touch on that in a second, as well as starting to bring in academic partners now to bring some rigour to the assessment of how these technologies will genuinely achieve outcomes and transformation to future operating models for the health system, and therefore whether those new hospitals, when they open, will actually work from day one, whether the demand and capacity modelling, everything we're doing for the secondary assessment of data at the moment, has resulted in a hospital that's the right size and has the right configuration and the right rooms. So I mentioned earlier that blueprint for digitally advanced hospitals. This is the result 5 years later. The list of 49 intelligent hospital capabilities. Back to my usual frustration, why are we calling it hospital? But anyway, so these are, or intelligent indeed. Now these technologies are effectively mandated as part of the business case for these new hospital sites. So that those 7 RAC hospitals that I mentioned earlier, Atos is supporting 2 of those at the moment, who are the sort of chronologically the first in the scheme. To produce the business case that will go forward to Treasury early next year. For the build of the new hospitals, we take one example, a total scheme size for that new hospital of about 1.5 billion, with about 9.5% of that being on the digital and data elements of the scheme. The digital data elements being categorised as these 49 technologies. 3 categories, and I'll let you read the list in the background, and I think the slides are going out afterwards, but 3 categories. So we've got the purple ones, the fabric. So that is the physical stuff behind the walls, absolutely. However, and most critically, I think for our interest in the room, also the introduction of significant additional data sources in that new hospital setting, bringing new data to our availability that's not been there before, the IoT data, the smart building data, the technologies in the rooms which will do falls monitoring. Wonderful stuff, useful core stuff. However, we're probably more interested in the pink and the light blue. So footprint technologies are more about the interaction, and again, this is where I get frustrated about them calling it the hospital capabilities. This is actually about how that new hospital embeds in its broader health ecosystem. So this is about remote monitoring, digital front door. How do we make sure that we have cohesive end-to-end pathways going out into community? How do we do step-up control of patients to avoid the patient coming into the ED in the first place? Digital therapeutics, treatment in the home, those sorts of technologies. We then touch on the flow technologies, and these are probably more introspective to the hospital building itself. So this is more about once the patient's in your hospital, how do you manage the end-to-end flow of in, treated, out the door? I think a fascinating programme from our perspective, and the reason we created that Centre of Excellence with industry. This is really quite experimental, and it's quite experimental when you have a really hard deadline. You know, these buildings go up and open to patients in 2029, 2030. If we get this wrong, if we haven't achieved the new operating models that these technologies deliver, those hospitals will not work on day one and will have corridor care, which just cannot happen. There's nowhere globally that's done all of this together. Each of these technologies at a sufficient maturity level has to have done somewhere globally, otherwise it can't be on the list. That was a category for us creating this list originally. But there is no one place where you can see all of these technologies and the data they consume and the data they create working in concert. If you want to go and see really good patient flow, you can go over to Oslo, you can see what they're doing over there, absolutely fantastic work in a sort of cluster of these technologies over here. If you want to go and see command and control of a hospital in the context of its regional health system, go to Humber River over in Canada. But there is nowhere that's doing it all together. Equally, the level of outcome needed from the implementation of these technologies is significant in the context of those new hospital buildings. The new hospital physical design, this hospital 2.0 concept up at the top there, so that physical design and how big you build this hospital and what layouts you have and what your rooms look like is predicated on all of these technologies being present and the new ways of working that they engender being fully adopted and embedded well before you go into that new hospital building. So it's a big experimental challenge for us to bring this all together and see if it works. For a lot of technologies, and as I said, a lot of industry partners and small and medium enterprise having to work in concert for the first time. Last, I think, reflection on this, I suppose it's what's missing from the data perspective. So 49 technologies. Each of these trusts I talk to their CIO, CFO. They definitely do not want to run 49 procurements and 49 technologies and figure out how all those are going to be plugged together themselves. What's also missing from here is the data layer that sits over the top. We do not want 49 silo data sets that we might be able to integrate through all the stuff we've done before. It's going to be impossible to bring the outcomes from this without figuring out how some of these data sets come together from a data architecture perspective before we do the implementation. Recognizing as well that some of these data sets are novel, certainly in combination. So have we really, anywhere globally, integrated a smart building data set into a clinical operational flow data set? We might need to here because we're going to be powering down, up and down our operating theatres dependent on what our lists show. Smart city data sets, that's very much part of this. Actually, can we predict our flow through the emergency department and influence our staffing levels hour to hour based on smart city data sets about the fact the buses are running late or that there's been a big car accident on the motorway up the road? These are all things that are assumed to be possible in the physical design and operating model. I would also, I think another interesting one for me, and perhaps last point before I wash up, we were having a discussion on one of the tables yesterday about the fact that secondary use of our clinical data is obviously absolutely key to getting this design right. We need to understand at a macro scale and over a longer term scale how our operational data feeds the design and the scale of these new hospitals. What we're seeing as part of the implementation of this and the sort of early experimental work is it's starting to become much more immediate and timely. So it goes from secondary use of data as research, which we have time to look at over a longer period and use to define the design of the new hospital, to actually the secondary use of data is going to be used to plan tomorrow's shift. It's going to be used minute to minute, hour to hour, and day to day, not month to month and year to year. And the example I gave on the table yesterday, one of the digital leaders who are working with one of those hospitals has a fantastic example of McDonald's. So she used to be a site manager for McDonald's a few years ago, and every morning the site managers get an email saying, well, based on this predictive analytics we've done, you're going to get 20% extra footfall than you would have expected yesterday. And that's because there's a football match up the road. And last year we had a peak on this day because this, and this was happening. Where's that in the NHS? If you're actually your operational manager, where's your flow data that's not just at the macro scale, do we do this week to week and month to month, but Tuesday the 5th of November, we've got a problem because. And again, that sort of immediacy of secondary use of data is something that within the context of the new hospital program moves from something that we know we should be doing and so on, but actually becomes mandatory because those emergency departments aren't going to be built big enough to not have that level of insight driving them. And I'll just close off because give Paul some time back, hopefully. So in terms of that Centre of Excellence offer, we are working with several of those new hospital sites at the moment. That industry consortium will be providing a laboratory environment, test the technology, extract the data, see what we can do with it. Physical and virtual demonstration. Strangely enough, the clinicians don't actually believe any of this stuff's real. So in doing the business cases, we sit there saying, oh, the ambient listening is going to record your conversation in your multidisciplinary team. You're never going to have to type anything up. And they go, oh, yeah, right, cool. So we need to do some work to persuade everyone that this is plausible. And then actually a key one is, and it's been mentioned already, is funding. So yes, the new hospital program comes with a nice lump of capital, which will fund the digital transformation of those systems. But actually the digital, it's not going to be enough. So looking at other novel ways that we can, between industry and the NHS, drive alternate sources of funding to get this transformation delivered. Thank you.
Thank you so much, David. Okay, so last in the line is, last but not least, Iñaki Gutiérrez-Ibarluzea. That is probably the worst pronunciation that I've made of his name.
But you are trying. And that is important. So it's trial and error.
But Iñaki is going to close the lightning talk.
So, Boreda, Egunon, buenos días, good morning. This was to show that, and I think it is tremendously relevant, the talk this morning from Tiago. I've been extensively working in health technology assessment for the last 25 years. And what it was described by Tiago this morning, it is what we have been suffering, informing decision making. Nowadays, I have the other hat. So it is, I'm the one that is receiving the information to make the decision. So it is also challenging because those are things that are the way that finally the things occur. Another thing that I wanted to say is I could have talked about what are the things that we are doing with trying to deal with data in terms of secondary use, but I wanted to make you feel discomfort in your seats. So first of all, I'm describing this because I still remember that my first meeting when I started working in health technology assessment, a manager told us, I wanted you, those that are providing me with information and evidence, as the drunk people to string lamps. It is to give me light, not to give me support. And I think it is important because most of the things that most of the decisions that we are taking in healthcare systems are based almost on nothing. And there are so many uncertainties, as it was described this morning by Tiago, because most of the things that we are introducing in our systems, any kind of technology, drugs, medical devices, and other type of tools, what we are using to make decisions are theoretical value. And in reality, we are obtaining much less. And this is one of the reasons by which, as we understood yesterday, and there are so many papers, there is, I would say, 20 to 30% of waste in the healthcare systems. And we as public officials, we should try to avoid that. The other thing, it is, I'm putting this cartoonist for two reasons. First of all, because I love him, but the second reason is that he's supporting my football team. So he's supporting Athletic Bilbao. For those that are not very keen in Spanish, there is a translation in the bottom. So one of the things that is important, it is what are we talking about in the healthcare systems? And when I studied quality, there are three things that are taken into account in systems: processes, structure, and outcomes. And what are we talking about in healthcare systems? Waiting list, average length of stays, lack of professionals, generational change, professional vocation, access to innovation. What is missing? What is missing? So we are talking in most of the cases about processes and structure, but we are not talking about what is important. There are outcomes, and outcomes from the perspective of professionals and from the perspective of patients, the clients. And if we are talking about health systems and not healthcare systems, we are missing the citizens. Nowadays, we are talking about real-world data. We are starting talking about proms, prems, and chroms. We are starting because for many years we have been talking about processes, data flows, and patient flows, and not about what is important to those ones that we are intended to take care. The other one, it is the finite budget. I don't know how many times I've heard we don't have more money. We don't have more money. For those that are not very keen in Spanish, once again, there is in the bottom, there is some kind of translation. So, budget. We learned when it was the pandemic, we learned that I don't know how much it was spent in the case of Wales, but in our case in the Basque Country, we spent 1 million more each day of the pandemic. 1 million euros more. So that supposed that we had a deficit in the budget in 2020 of 300 million euros. But no one took care of that because it was important. We should move economy. We should be out of the lockdown, and there was a reason. So anyone put any kind of effort in terms of making things different. So budget was not that important. But once again, being public officials, we still have some kind of mandate in terms of doing things different. My question is, what was first, the answer or the question? We are talking these days about technology. But technology, it is the answer. It is not a question. So we are putting first the elephant in the room without thinking about why the elephant is in the room. And I think it is tremendously relevant. So we forget the question or questions, and we focus on the answers or the technology. I've heard so many times, well, what about introducing this new medical device in the hospital, and which the consequences would be? And it's the contrary. Why do we need that medical device? And what are the outcomes and the value that we will obtain with that investment? And I think it is also tremendously relevant. So I'm not advocating with wine, although we are a region that we are wine producers, but it's true, wine is not the answer, but you forget the question. So I think also it's tremendously relevant. What we have learned, I was shocked with the last I would say report that was written by I would say very clever people, Imperial College. So they put the future state of health and healthcare in 2035. There was a report from Lord Darcy saying we are almost bankrupt. There are big issues in the NHS right now, and we need to solve them. But I was shocked when I heard the future of the NHS is focused on becoming a more digital, preventative and community-focused healthcare system with a greater emphasis on personalized care and the use of technology to improve efficiency and outcomes. But when we go in depth, he put key strategies include leveraging artificial intelligence and genomics, integrating care across diverse settings and providing patients with tools and information to manage their health. Nothing about what is the value that we are going to provide to our citizens and which the problems that we have right now in reality in health. And if you go in detail to the report, it put integrated data to deliver impact, the digital front door. Well, it was something related to health. It was the obesity breakthrough. And then the wearable revolution, the genetic gateway, AI to drive patient power and productivity, and robotics to support precision. Everything is around technology. nothing around health, nothing around which our problems are and how those technologies could mediate in improving the health status of our population, and nothing about public health. I was very, I would say I was very shocked with the talks this morning, and I'm very followed because I'm also a public health advocate and clinical epidemiologist, so that is also important on my side. So we have learned almost nothing. Data. I was used to use this quote, so it is from Edward Deming, a sociologist, and he was one of the persons that moved Japan in terms of improving during the 60s and 70s. And he was saying, without data, you are just a person with an opinion. And it is more or less what we have done in the last years in terms of planning in most of the healthcare systems. But I found this other quote more recently, that is, without an opinion, you are just a person with data. And I think it is tremendously relevant. If you don't have, and if you don't make the correct questions, it is hard to take the best answers. So I think we are nowadays in the data revolution, but still, we are lacking the correct questions. Yesterday I learned the concept of AI, and not just of IA. And there is a famous Mexican song that is ay 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 ay. So it is I don't know. So I think AI. I'm advocating in favor of AI, but we need to have the correct questions for AI. Otherwise, we will finish with ay ay ay. In the most accurate world, I don't know if you know this guy, Adrian Newey. Adrian Newey is one of the top engineers in Formula One. Nowadays, he's I think he's the one that has changed the Formula One concept, because he was not having the best engine, but he has the best car. That is the most important thing, because he was fitting the car to the needs of Formula One. And nowadays and recently, he has moved from Red Bull to Aston Martin. I'm following because I was following Fernando, so that is the Spanish driver, not from my region, unfortunately, but still important. And he was saying, it's fair to say that independently that we have very accurate data because of the sensors that we have in the car, I cannot provide a good car for 2025 for Aston Martin. We need other type of questions, and I don't have the sensors located in the place that are needed in terms of making a good car in 2025. So, independently that I could have the best data, if they are not located in the areas in which I need, they are useless. They are useless. So, all that science is not gold. And what about AI? And we need to be very careful. I found this, that a study shows AI can decrease clinical skills. And it was written recently. You can find I think the quote and the reference there. And it was written in I would say, a very prestigious journal, that is Lancet. What is more, when you went in depth to the study, those that started using AI, especially radiologists, were losing the skills that they have. And what about when technology is broken? Same applies with nowadays robotic surgery. Nowadays that we are talking about robotic surgery is the perfection and so on. When we have a problem and we need to do open surgery, the problem is that we don't have trained professionals to do so. And that is a big issue. This is from NICE some years ago about digital health technologies and how they classified. And they were looking at the different levels of risk. And when we are taking decisions, we have intended and unintended consequences of the introduction of a technology. And they put in in three levels: Tier C, Tier B, and Tier A, and it was related to the risk. Similarly, we have done in the European Union about the classification of digital technologies, including AI solutions, in terms of risk, and we classify class 1, class 2, and class 3. And AI solutions based on risk, if they are just, and I'm reinforcing this, just informative, but information is changing your mind, so we need to be conscious. The second one, it is decision support systems, so still you have the right to decide, or those that are doing independently, without any control by humans. And that is the risk thing. Once again, I'm not against technology. I'm very in favor of technology, and they are going to solve most of the problems that we have. The other thing is how we are measuring and how we are prioritizing, and this is also removing from my seat, and it's keeping me not sleepy at night, or not sleeping very well. When we are talking about how we are making decisions on the basis of the tools that we are obtaining, probably you have heard that we are using cost effectiveness, we are using things like Qualis, things like DALIs. But in most occasions, once again, what we are promoting are things that are related to healthcare and not to health. There are new tools that are proposed in terms of also put at the highest level public health interventions, like PALIS. This is new ways of measuring the value, PALIS. So PALIS is related to something that probably would be of interest to companies, because that is related to productivity. And I think it is pretty relevant, because they put how much we lose as a society for someone that has a pathology. And I think it is tremendously relevant, because we are losing someone that is doing things that could be helpful for the society as a whole. And we are not talking about just pathologies, but being healthy or not healthy. And I'm finishing with this. Life is what happens between meetings and forums. So the old hymn for eskerrik asko. Thank you very much.
Thank you.
Everybody is looking for better healthcare solutions. What if AI could be the answer? AI in healthcare isn't just a buzzword, it's revolutionizing patient care. With AI, we can achieve more accurate diagnoses and personalized treatments tailored specifically to each patient. AI systems analyze vast amounts of medical data at lightning speed, identifying patterns that might be missed by human eyes. This means early detection of diseases, fewer errors, and more effective treatments. But the magic doesn't stop there. AI helps streamline administrative tasks, giving healthcare professionals more time to focus on what they do best, caring for patients. The result? Enhanced patient outcomes and improved quality of life. So whether it's predicting patient needs or making real-time decisions, AI is transforming healthcare, one patient at a time. Embrace the future with AI-driven healthcare solutions. Because better health outcomes start with better technology. Ready to take the leap? AI in healthcare. Better diagnoses and treatments. Making healthcare smarter, one innovation at a time.